My name is Amber Clark, and I will be discussing the impact of provider recommendation quality on HPV vaccine uptake. The significance of this issue is that human papillomavirus causes 30,700 cancers in men and women annually, and HPV vaccination can prevent about 28,000 of these cancers. The uptake of HPV vaccine is markedly lower than the National Healthy People 2020 goal of 80%. And in Kansas, in 2015, HPV vaccination rates lagged behind national rates by 10% for males and females, which ranked us among the lowest HPV vaccination rates in the country. Provider presentation, whether weak or strong, may impact a parent or guardian's decision to vaccinate or not vaccinate against HPV. The purpose of this presentation is to provide a review of 3 primary research studies to determine association between healthcare provider recommendation quality and HPV vaccination uptake. Methods for identifying 3 primary research articles included database search of Medline, PubMed, and CINAHL. Search phrases included HPV, provider recommendation, caregiver, and HPV vaccine uptake. Search limits included the years 2006 to 2017, English language, United States, and peer-reviewed. Eligibility criteria included primary peer-reviewed studies occurring in the United States involving either sex, comparing provider recommendation quality and HPV vaccine uptake. Study number 1 by Gilkey et al. Investigated the association between provider recommendation quality and HPV vaccination receipt or uptake. The authors conducted a national online survey of 1,495 parents of 11 to 17-year-olds from November 2014 through January 2015. Respondents were members of a standing panel of U.S. adults maintained by a survey research company. The survey assessed receipt of provider recommendation by asking, has a doctor or other healthcare provider ever told you your child should get the HPV vaccine? Parents who indicated that they had received provider recommendation reported on 3 quality indicators that were identified through literature review and CDC recommendations for provider communication on HPV vaccine. The survey assessed 1. Strength of provider endorsement, or whether the provider said HPV vaccine was very or extremely important. Number 2, prevention message, or whether the provider said HPV vaccine prevents cancer. And number 3, urgency, or whether the provider recommended same-day vaccination. These 3 items were combined into an index of overall recommendation quality by awarding 1 point for each indicator of quality, calculating the sum, and creating 2 categories: low quality recommendation, receiving scores of 0 to 1, and high quality recommendation, receiving scores of 2 to 3. In the results, overall 48% received no provider recommendation for HPV vaccine. That's just under half of all participants. Of the remaining participants, 59% were not recommended same-day vaccination, indicating a lack of urgency. 16% of parents received a low-quality recommendation, and 36% received a high-quality recommendation. Higher recommendation quality correlated with HPV vaccine initiation. Compared to no recommendation, high-quality recommendations were associated with over 9 times the odds of HPV vaccine initiation, and over 3 times the odds of follow-through. Receiving a low-quality recommendation versus no recommendation was associated with over 4 times the odds of initiation. Higher recommendation quality was associated with less HPV vaccine refusal and delay. Parents of younger adolescents, 11 to 12 years old, and male adolescents reported fewer high-quality recommendations. These findings are consistent with prior studies in which healthcare providers have expressed a preference for recommending HPV vaccination to older adolescents rather than the 11 to 12-year-old age group. And the focus on providing high-quality recommendations to girls over boys may reflect the history of practice guidelines that initially recommended routine HPV vaccination for girls only. Strengths of this study include use of cognitively tested survey items, a good response rate, and a large national sample of respondents. Also, these study findings agree with other nationally representative surveys. Limitations of this study include the cross-sectional design, preventing assessment of directionality of the relationship between recommendation quality and HPV vaccination behavior, and self-report, particularly when considering what constitutes a provider recommendation. Study number 2 by Fu, Zimet, Latkin, and Joseph sought to study the relationships between parental trust in healthcare providers, strength of healthcare provider vaccine recommendation, and HPV vaccine acceptance among African American parents. Participants were recruited from an urban academic medical center between July 2012 and July 2014. The study included 400 English-speaking African American parents or legal guardians of children ages 10 to 12 years old who had not previously received HPV vaccine and were offered HPV vaccine by their healthcare providers that day. An oral survey was administered in 2 parts. Part 1 took place prior to the healthcare provider encounter, and it assessed respondents' age, gender, highest level of education, history of vaccine refusal, whether older children had received HPV vaccine in the past, the child's age, gender, and whether the child was overdue for other vaccinations. Part 1 also assessed parental trust in different sources of vaccine advice, including your child's doctor or nurse or other healthcare providers, medical websites such as the American Academy of Pediatrics, and government websites like the CDC, and also attitude toward HPV vaccine. Items assessing attitude toward HPV vaccination were adapted from a previously validated scale of vaccine beliefs and modified to address parental respondents and to specify HPV vaccine. Part 2 was administered after the provider encounter and assessed whether HPV vaccine was offered. Survey participants' impression of strength of healthcare provider HPV vaccination recommendation and overall impression of the healthcare provider. Recommendation strength responses were graded as not very strong, somewhat strongly, and very strongly. An overall impression of the healthcare provider was evaluated on a 1 to 10 scale, with 1 being the worst and 10 being the best. With results of this study, 42.9% of vaccine acceptors and 26% of refusers claimed they received a very strong recommendation. This is statistically significant at the 0.001 level. While 99% of parents trusted their children's healthcare providers at least some, those who trusted their children's healthcare providers a lot had over double the odds of accepting the HPV vaccine as compared to parents with lower levels of trust. Also of note, only approximately half of participants accepted HPV vaccine for their children after it was recommended by the healthcare provider. Thus, healthcare provider recommendation may be important, but insufficient to persuade many African American parents to vaccinate. This study increases awareness of and sensitivity to common negative vaccine attitudes and beliefs in the African American community, further expanding the current body of evidence. Study limitations include observational design, limiting ability to determine causation. The survey was conducted in a medical setting, assessing health beliefs which could influence responses. Parental awareness of the survey purpose may have influenced vaccine acceptance or how healthcare providers recommended vaccination. Lastly, trust in healthcare provider was high overall, and therefore findings may not transfer to settings of low trust in healthcare providers. Study number 3 by Brewer et al. Was a parallel group randomized clinical trial with 30 pediatric and family medicine clinics in central North Carolina. Clinics were randomized to receive no training, which was the control group, announcement training, or conversation training. Announcements were defined as brief statements that assume parents are ready to vaccinate, and conversation training was defined as engaging parents in open-ended discussions. A physician-led 1-hour in-clinic training at participating clinic sites. Training was provided to prescribing clinicians and staff who may support parent decisions to vaccinate. The North Carolina Immunization Registry provided data on the primary trial outcome, which was 6-month coverage change in HPV vaccine initiation as defined by a child receiving greater than or equal to 1 dose of HPV vaccine for adolescents aged 11 or 12 years. Clinics were selected if they were a pediatric specialty or family medicine clinic, had 100 or more patients aged 11 or 12 documented in the North Carolina Immunization Registry as of March 2014, were located within a 2-hour drive of the primary study site, and had at least one physician who provided HPV vaccine to adolescents aged 11 or 12. Clinics were excluded if they had taken part in quality improvement to increase HPV vaccination rates in the previous 6 months or plan to do so in the next 6 months. Clinics could not be blinded to the training type they would receive, but they were not made aware of which group they had been assigned prior to receiving training, and patients were not made aware of provider training. In the results of the study, 6-month increases in HPV vaccination coverage were larger for patients in clinics receiving announcements versus control clinics. Clinics that received conversation training did not differ from the control arm on HPV vaccine initiation among adolescents ages 11 or 12. And that was significant at the 0.05 level. Patients receiving conversation training did not differ from those in control clinics with respect to changes in HPV vaccination coverage. Strengths of the trial include an effective, brief, and standardized intervention, having clinic-provided data on vaccinations, and having a large sample of vaccine-eligible adolescents at trial clinics. Weaknesses were that trial findings may represent motivated clinics, as many eligible clinics were unreachable or declined. This study took place in larger urban and rural clinics of the southeastern United States, and it is unknown whether these findings will generalize to large managed care organizations, smaller clinics, or to clinics that do not use immunization registries. This slide compares all 3 articles side by side. You can see that Study 1 and Study 2 were both cross-sectional studies, which did limit them because we couldn't tell directionality, which I had mentioned earlier. You can also see that exposure was the same for all. So we were measuring provider recommendation quality in study number 1, parental trust, so we added trust in study number 2 with African Americans. And then with number 3, we were looking at announcement versus conversation training, which all fell into recommendation quality. And then for all 3 articles, the outcome was similar, with study 1 association between provider recommendation quality and vaccine uptake, or whether the parents chose for the child to be vaccinated. And then the same for study 2, HPV vaccine uptake. And then study 3, change in HPV vaccination initiation between baseline and then at 6 months post-intervention for adolescents ages 11 or 12. For outcome measurements for study 1, 2, and 3, they all use different methods to measure, and we will talk results on the next slide. This slide reviews Henneken's criteria for all 3 studies. In study 1, we see that compared to no recommendation, high-quality recommendations were associated with over 9 times the odds of HPV vaccine initiation and over 3 times the odds of follow-through. And we also see that low-quality recommendations were more modestly associated with initiation at 4 times the odds of initiation but not follow-through. And all of these were found statistically significant at the 0.01 level. These findings offer some evidence to address beliefs held by some providers that strong recommendations will elicit resistance from parents and are therefore best avoided. In study 2, we see the stronger the healthcare provider recommendation for HPV vaccination, the higher the odds that the child will receive it, though adding the variables strength of healthcare provider recommendation and parental trust in healthcare providers to a multivariable model that already adjusted for socio-demographics factors and parental vaccine beliefs only improved the pseudo R-squared from 0.52 to 0.55. On study 2, under confounding, parental awareness of purpose of survey may have influenced vaccine acceptance or how healthcare providers recommend vaccination. The authors do not think this was substantial because the HPV vaccine uptake among participants mirrored that of the entire health center's population. and under study 3, 6-month increases in HPV vaccination coverage were larger for patients in clinics receiving announcements training versus control clinics, and that was at a 5.4% difference. And this was significant, but it was weak. I do want to point out, though, that even though it was weak, these findings represent 37 more patients who initiated HPV vaccination in the announcement group. In conclusion, all 3 studies show association between HPV vaccine uptake and strong, directive, high-quality provider recommendation. And future studies should seek to further understand what constitutes strong communication regarding HPV vaccination. They should compare effectiveness of announcement training in clinics with low and high vaccination coverage, explore effective ways to ease parental concerns, and culturally tailor parental trust building and delivery of strong HPV vaccination recommendations to African American parents. Recommendations for practice include talking points for parents of younger patients to include the opportunity to vaccinate before exposure and to achieve stronger immune response, which may increase vaccine effectiveness. Announcements are thought to normalize HPV vaccination for both providers and parents, making providers more likely to raise the topic and parents more likely to consent to vaccination. Fu, Zemet, Locken, and Joseph support strong recommendation for HPV vaccine when there is a foundation of trust with the provider. Trust was a key element in that study. And interventions should focus on increasing pro-vaccination messages through medical and non-medical sources for best receipt by the African American population. And this was based on their findings that the African American population generally listen and trust their healthcare providers, but they also rely on family and friends and outside sources, both medical and non-medical, for their healthcare information. This concludes my presentation. I thank you for your time, and I hope that you have found this helpful. Thanks.